Hello, everyone. Welcome. Good evening for those that are where? In the United
Or
States.
good morning if you're joining from Australia.
That's right. Good afternoon.
Please do let us know if
Welcome.
you're joining from Australia.
Yes. Thank you, Sandra, Valentia. Good
Minnesota.
evening. Wow, Colorado. Welcome, everyone. Illinois, Peru, Washington, Indiana. Hi, everyone. Please make yourself home. It's going to be a great evening or morning that is awaiting us in the next few minutes. Thank you for joining us.
Minnesota, the
Boston,
UK.
New Zealand. John, what about that?
That's very good.
Yes, California, Phoenix, Tampa, Kentucky, Australia. We have people from
Korea.
Australia,
I just
John.
saw Korea.
Guatemala. Let's see if we have people from Panama, John. I'm from
I mean,
Panama.
Idaho, very cool. Toronto, very cool. Boulder, very cool. Portland. Uh,
Seville, Spain, Puerto
we're looking
Rico,
for Sydney. Anyone? Jacksonville,
San
St. Augustine.
Agustin, Florida. Wow,
Hi,
welcome,
Irina. I work with
welcome.
Irina.
Welcome, everyone. Iran, awesome. Columbus, Ohio. I don't see anybody from Panama yet, or Colombia, John.
Yeah.
What is happening to our people?
Sydney. Jen from Sydney. Very nice.
Yes, North
And live from
Carolina.
Sydney. How cool is that?
Hello, everybody. California. Excellent. Chicago, Nebraska, Venezuela. No, Venezuelan in Houston. Okay, welcome, Venezuelan in
And
Houston.
if
Panama. I saw some Panama.
just to chime
Oh,
in real quick for everyone's
yes.
benefit, it takes a little bit. We had over 1,500 registrants for this webinar. Everyone's excited to see our two panelists. Analia is going to introduce them shortly. And it takes a little bit for everyone to kind of trickle in from the Zoom waiting room. And so we don't want anyone to miss it. We think very, very highly of our panelists. And so we want to make sure and provide some context for the webinar. This is going to be a little bit different of a format from what you're typically accustomed to. So we're just geeking out on the chat and the locations everyone is coming from, but we'll get started here in just a minute. Sorry to chime in there, Analia.
No, thank you. Because you probably were wondering, why are you greeting for so long, Analia? Get on with the program, right? So that was good to give people context,
Nargis from
right?
Iran. Absolutely. Hello, Dewey from Brisbane, Australia, and Ron from Guam. Very cool. Very cool.
Excellent. Thank you, everybody. Welcome, welcome. Wow. It's so exciting to have people. Waterloo, Ontario. A lot of people from Boston, John.
A lot of interpreters in Boston.
Yes.
Nairobi,
Nairobi.
Nairobi.
Yes. Wonderful. Los Angeles. Hello. More people from Indiana. I have seen like 3 participants from Indiana. Fantastic.
Mohammed from England. Yesley from
Yeah.
Seoul.
Okay.
Mm,
Welcome, everyone. Yes, and you can Egypt. Wonderful. Okay. Should we give it another minute or two? Should we start? What do you think, John?
I think we can get started.
Okay.
Okay.
Everybody, as you come in, we are very, very excited. And what we want to do right now is to welcome each one of you to today's webinar titled Certified, Irreplaceable, Indispensable, the Future of Healthcare Interpreting. Thank you for joining us. We are delighted to have participants, as you see, from around the world. For those of you who don't know me, my name is Analia. I am the Senior Manager at Cross Cultural Communications, and I am joined by John Arroyave, our CCC's Director, and myself, Zabala, our Program Manager. who will be managing the chat and sharing helpful links. Okay, so today's webinar, as John mentioned, is going to be a little bit different. It will be presented in a panel discussion format. Rather than traditional presentations, our two guest speakers will engage in a guided conversation. Uh, I and John will serve as the moderators, introducing a series of 5 questions that explore uh, today's topics from different perspectives. The questions will alternate between our panelists, giving each one the opportunity to speak and to share their experience, their expertise, and their insights. As the discussion unfolds, our panelists may also build upon one another's comments, creating, as we know, a dynamic and engaging conversation. After our panel discussion, we will reserve time for live question and answer session. This will be your opportunity to ask questions and hear directly from our panelists. If you have questions during the discussion, please submit them in the Q&A or the chat feature, and we will address as many as time allows. We really hope that you will enjoy today's conversation, today's webinar, and that you will leave with valuable insights. Again, thank you for being here tonight, and John will introduce our presenters. Thank you, John.
Thank you, Analia. Yes, and thank you all very much for joining us tonight. We're really excited to have Natalya, Mytareva, and Michael Nemarich from NAATI from Australia. So Natalya, Executive Director, everyone knows Natalya of CCHI. Um, she is the Executive Director of the Certification Commission for Healthcare Interpreters. She's also Vice Chair of the National Commission for Certifying Agencies, so NCCA. NCCA accredits CCHI. CCHI is an accredited certification. And Natalya, from 2000 to 2013, was actually communications director at the International Institute of Akron, which is a refugee resettlement agency in Ohio. She developed and taught several courses for healthcare interpreters, for court interpreters, with the focus on languages of lesser diffusion. She is a recipient of the 2025 Alexander Goad Medal from the American Translators Association. Did I pronounce that correctly, Natalia? Very good. And a 2023 Language Access Champion Award recipient from NCIHC. Natalia is a Russian interpreter and translator. She actually started her career as an instructor of interpretation and translation at Volgograd State University in Russia. She holds a combined BA and MA in philology and teaching English as a second language. And our other esteemed panelist is Michael. Michael is actually the is the manager of national operations at NAATI in Australia, which is kind of the counterpart to CCHI, but the certifying body in Australia. He has worked with NAATI since 2018, overseeing the company's test delivery, IT, customer service, and state office network. He's also deputy CEO. Michael has worked for the past 18 years in social enterprise and not-for-profit management, primarily with First Nations Australians, prior to joining NAATI. And he specializes in businesses that use commercial activities to fund their benevolent goals. His time living and working with Indigenous communities who were English second language users embedded his appreciation of the critical role interpreters and translators play in the connection of cultures, communities, and businesses to each other and the outcomes they achieve. So thank you all very much for joining us today. We're really excited. We've been planning this webinar for some time now, And I do want to mention that it was actually 4.5 years ago that NAATI and CCHI and Marjorie Bancroft hosted a webinar with us. So we're really excited to have kind of a full circle moment. Um, but we wanted to just kick it off by asking the question, and this will go to Michael first. Um, so Australia and New Zealand have both taken really notable regulatory steps in the world of interpretation in recent years. I would love to hear a quick summary of what's actually happened. Um, but based on that, I would love to hear your perspective for interpreters in the US. What is the single most transferable lesson from those models? And what structural barrier in the American system would need to shift to kind of transfer those improvements, if you will, from Australia to the US?
Okay. Thank you. Pleasure to be here. I think the starting point is NAATI's been doing this since 1977, so we've been around for a while. We were formed. Australia had what was called a White Australia policy up until the early 70s, and when that was disbanded, we introduced multiple schemes to improve multiculturalism and social cohesion. NAATI is one of the outcomes of that. And ever since that time, we've been a champion for, I guess, consumer guarantee, that the person that can get as an interpreter or translator actually has the skills required to do the job that's needed. To add New Zealand to the mix, I think it was 2016, the New Zealand government commissioned a report that looked at their interpreting and translating sector and what the requirements were for it to become more professional. A very similar migration mix as Australia there. And they looked around the world for the best system, and they decided to come across the water to us. And since 2024, we've been the official certification system of New Zealand for interpreting. They use the ISO standards for translating, but for interpreting there. Regulatory steps. I think some of the big things, it's benefited in New Zealand by legislation. In Australia, it's a lot of policy, but it's embedding into government procurement policies the requirement for people that are working in the sector to be professional. That's easy in Australia, I guess. There's only one professional outfit, which is NAATI. We are only the standards and certification body. We're not a training institution. We're not the professional association. We are solely the certifying body. And our database, currently we have 198 languages represented across 8,800 practitioners. And each one of those practitioners needs to recertify every 3 years by adhering to a code of ethics and ensuring that they do ongoing professional development. So back to the specific question and how that benefits, I guess, I'm no expert in the United States system, but the coordination between states and having it as part of government procurement policies, I think, is one of those critical things that you can't do without. Government is by far and away, particularly in legal and health, the major procurer of language services. And if they are not on board with the need for professionalism, then the whole industry is going to struggle.
Got it. Got it. No, very good point. So
Let me jump in here.
Yeah, absolutely.
Of course.
Yeah, so I think Michael just pinpointed exactly that transferable lesson, right? It's not the structure of a program, it's not the test format. It's the principle that standards of certification will stick when the payer requires them, right? So if you think of what he just briefly described, what New Zealand did in 2017 after that report, they did something that unfortunately the US almost never does. And New Zealand funded a multi-year transition and subsidized testing, and it required agencies, that public sector that engages with New Zealand government, to engage only interpreters who hold a NAATI credential. right? So certification followed the money in the right direction in this case, right? That's the major thing that unfortunately it seems almost non-transferable, but yet still it does, because while we do have the disconnect in the US between payment and the credentials, we have laws that require language access, like Title VI of the Civil Rights Act or Section 1557 specifically for healthcare context. But these laws, unfortunately, don't define qualified interpreter in a way that requires certification, right? And on top of that, we have only a minority of states that reimburse for interpreting services through Medicaid or Children's Health Insurance Program. So in fact, in the US, hospitals carry language access as unfunded overhead most of the time, right? And what do people do with overhead? They minimize it, right? They try to minimize it. Whenever they budget, they try to shrink it. So we cannot import a government-owned structure as NAATI to the US directly. However, and especially in the current situation when, we've just had the administration issue Executive Order 1424 about English as the official language of the country. We had the rescission of disparate impact provisions of the Title VI regulations by Department of Justice. But what we have in common with Australia is we have states, right? And we could translate their practices at the state level. We all need to advocate on the state level for expansion of Medicaid payment and for interpreting services. We could advocate at the state level to requiring hospitals to hire only certified interpreters. And we have a good example. This past December, the state of New York showed to everyone that it can be done. They adopted a law, one of the most robust laws in the union, that requires language assistance program in every public hospital in the state. And it set parameters of what is qualified interpreters that could be tied to certification. And another thing that Australia's model gets from the being owned by government is the fact that they are held publicly accountable through that mechanism. In the United States, we can adopt, and we do have a good mechanism that holds certification programs accountable, and that's called accreditation. And the accrediting body in the United States, it's a nonprofit organization called the National Commission for Certifying Agencies, NCCA. So if you're holding accreditation through that body, you are held publicly accountable from the government's perspective, budgeting, testing practices, credential requirements and policies. All that is audited by that third independent party, kind of like the Joint Commission audits the hospitals, right? So we do have the mechanisms. They're different. But remember, we're in the business of interpreting and translating. We convert meaning. And that's what we need. We need to take the principle of trying to follow the money and make it flow in the right direction, but adopt it maybe at the state level at this time. In general, I want to point out that neither like Australia government nor New Zealand, they did not spend time. I mean, they did do it, but they did not focus on persuading interpreters to value certification, right? They required buyers to utilize certified interpreters, and that's the game changer. The game changer. Yeah.
So it's ultimately, we still need to talk about the inherent value because it has to start somewhere from a grassroots level. But what Natalya is saying and the example we're taking from Michael is that everything kind of follows the money, so to speak. If we make it a procurement practice at the highest level, starting with states, that, hey, we need you to work with certified interpreters. As a bit of a small segue, but how would we kind of reconcile that with the lack of interpreters? So you're saying ultimately, if we require it from the money perspective, we'll get more interpreters. We just don't have enough interpreters to go around just yet. is ultimately what. Yes, Michael?
I might jump in on that. Yeah. I think, and I know this is probably going to come up in a future question, but when we look at industry, standard economics of labor markets is where there is demand, price usually goes up. The price goes up, that encourages more people into the industry until prices stabilize. Unfortunately, that's not something that often happens in the interpreting sector. Which, if you're happy for me to continue on that path rather than have the question come up later, I can talk about it now. There's multiple factors in that. To be blunt, I think the starting point is some racism in there. People should just speak English is problematic. NAATI has a interesting space by in Australia we do sign language, which is Auslan here, as well as Indigenous languages. So we have a full view, I guess, of multiple interpreting very general figures. So no one quote me on these, but roughly Auslan sign language interpreters are paid double the amount that migrant language interpreters are, and they are have better conditions as well. You know, multiple people on site, better preparation, etc. So when we think of that in a societal context or the procurement guidelines, people are looking at one as a disability and we need to do something with that. The other one they're looking at as, well, they should just speak English. And so I think there's an inherent racism there. I think one of the other problems is the nature of the workforce. 71% of practitioners that are registered with NAATI are female, and it's because it's seen as a care role rather than a risk mitigation role like a lawyer or something. So we know that social work care roles are often undervalued, and we know that casualised female workforces are very often undervalued as well. And I think that also puts the pressure on the system. And then you add into that non-certified people still being engaged that are migrant and female usually, who are being costed very low. So I think we've got a lot of factors in this that if you could actually fix the procurement and say, we are only going to use certified professionals, then the laws of economics say that that should over time improve the situation. Unfortunately, we've still got so many factors working against that. It's very challenging for the highly skilled professionals in this profession to make a decent living out of it.
Very nice. Thank you,
Thank
Michael.
you so much, Michael. Okay, let's move to the second question. And this is, you can start with this one, Natalya, and of course, Michael, you can chime in anytime you want. Okay, for an interpreter who is already certified, but struggling to make the case to hospital administrators who see language services primarily as a cost center. The question is, what concrete taking points of data points from your organization's research would be most persuasive?
Well, definitely is a good question. It seems like, on the interpreting webinar, we talk a lot about economics, and I think that's an important thing for all of us to understand. We need to be very educated in this matters. So I think the interpreter should start with trying to reframe the whole issue for administrators, right? Because when an administrator calls language services a cost center, it would be futile to argue that, oh, the interpreters are worth the cost, because that accepts the position of already services within that cost center. Instead, we need to change what they count as costs, I think, because a cost analysis that leaves out clinical errors, readmissions because of non-having interpreters, lawsuits, and the Joint Commission accreditation findings. If that cost analysis excludes these, then it's not an analysis. This is just an assumption. And I think many administrators are just not really aware of what interpreting services provide them. right? And we need to bring data to them. Last year, in 2025, we conducted the first global workforce survey, and we, discovered that, the quality control in our institutions is that are, either health systems or language companies is very minimal. Only 35% of employing organizations require certification.
Wow.
And there are 26% who do not even require a language proficiency test when they hire the individuals to interpret. So, and in this kind of context, right? Well, on top of that, the other number I can share is 43% only require healthcare interpreter training when they're hiring healthcare interpreters. Right? That's the
very
reality
concerning.
of the United States, right? And so in this context, what you can tell the administrator is ask them a question. Can you prove the competence of every person interpreting in your building to a Joint Commission surveyor, to a plaintiff's attorney? How can you prove that competence of the people that you work for you? And the only option truly is a third-party certification, right? That's a standard, scalable option
Vetted.
that will drive you, and prove to you the quality of this. And so it's not just about being, an expense, right? We need to remember that, we are not an expense that cannot be billed to a patient. We are a clinical support to the staff too, because whenever people talk about interpreting in the United States, I'm afraid most of the time they think interpreting for the patient. Excuse me, there are two people in the room, right? Or in
Yes.
Zoom at that time. So we're interpreting equally for both. And I think that shift in understanding can only happen if we interpreters take the data to these administrators. And, I'll put later in the chat the link to the report that's available on our website, and just show them, like, you see, you cannot do anything else but having your workforce certified if you truly want to be meeting all the requirements or mitigate the risks that you would encounter. And also thinking forward about the wonderful next shiny thing, AI, right? Vendors are claiming that interpreting by AI has the same quality or superior to certified interpreters. They base these claims when they take, static control data sets of the full transcripts of the encounter, and then they say, look how wonderful that is. But they never tested that data in the real time.
Real world.
Zero context interpreting when you don't know what the next moment will bring, right? How accurate that system will be. And the only people, again, in that administrative sphere who can tell them whether that tool is valid are the certified interpreters. So again, just think, our work should be to change that mindset. We're not a cost center. We are a service that could be counted as clinical service in some case, sometimes support service, but we definitely, have capability to make the system thrive and not just be an expense to them.
Excellent.
Well,
Excellent.
thank you, Natalia. Michael, do you want to add
Yeah, I
anything?
certainly can. I mean, completely agree with everything Natalia said there. I can probably add some statistics to that. I would start though with an analogy of, isn't it funny that we think that anyone that can speak two languages could be an interpreter, or that without any testing at all that we would accept that fact? But in a profession such as the law, where the law is freely available to anyone that wants it in English, we still think that the cheaper you go, the worse it is. And the more you pay, the better. So you want to pay $500, $1,000 an hour for a lawyer, even though the law is freely available, all on the
You can
web.
read it. Yeah.
You can read it.
Yeah.
So why would we price one interpretation of something written into a proper context from another? Like, why would we not value that? It's the same thing. And I think for me, that framing of the question around, it is not social good we're providing. It is, clinical support. It's risk mitigation. It has a value here. That is a critical point that I don't think we get to enough. We do, I believe in the humanness of it, but the humanness isn't the thing that makes people pay for professionals. And I think that risk mitigation is important. So a couple of stats, and I can share this with the team so they can post it out to attendees later. But the first one for me, there was a study in one of our state hospital systems where they put on professional in-house interpreters. And they showed that there was a reduction in bed stay days in hospital from 9.14 to 5.9 when an interpreter was used and needed it. From my basic research this morning around the cost of a hospital bed in the US, it's about $3,000 a day. So if you can reduce it by 3.24 days, the $100, if you even spent $100 on an interpreter, has just saved you $11,000.
Wow.
You could employ a full-time Burmese interpreter to sit in the tea room of that hospital and do 1 day of work a year, and they would have doubled their return on investment. So if we can really think about that, hospital beds are not easy to come by. We know that there's problems with waiting rooms. Hospitals want to get people through quicker. Doctors can't get people in. So when we start framing it like that, you could reduce by 1/3 the amount of time that person is there and save $11,000 in the process and take pressure off the system for maybe 1 hour use of an interpreter. That's pretty worthwhile. Another statistic, similar study, 24.3% readmission rate within 30 days for a patient that needed an interpreter, reduced to 14.9. Similar scenario. Self-discharge rates. There's some good research particularly in Aboriginal Australian towns where 3/4 of people didn't know why they were there, and 20% of them just walked out, which then leads to further pressures on the health system, where if someone was there, it would have worked. I read a study a few years ago, it was 2011 study in the US that even showed that bilingual communicators, so not even professional interpreters, there was one hospital that reduced its expenditure by $1 million over 2 years. It was a 6-to-1 return on investment from having people there that could actually explain to people what was happening. And when you put all of those things together, how can you not justify spending money on a professional? It's really quite extraordinary that we would think that that's a cost or time that you wouldn't use. Likewise, I could just keep saying statistics, but everyone will get bored. But 1 in 40 malpractice suits in Australia is due to non-interpreter use. And they're all just numbers, but literally in the news 3 days ago here in Australia, a Vietnamese woman died through a UTI complication because she didn't have an interpreter. But that's the human toll. It's literally a death because someone just went, it's okay, you don't need someone. Or you'll use your child to interpret it. An 8-year-old doing cancer diagnoses, or it's just insane that we would think that that's appropriate.
Those statistics are really something, and I think it really brings it home when you think of the human element and the reality of the human element. I mean, these are children that are interpreting. I wrote another statistic in Belgium about the impact on mental health on children when they're first forced to interpret for their parents. It really is quite a lot. There was actually Sarah Stockler-Rex, one of our authors on one of our textbooks, actually posted just yesterday on LinkedIn. Ad hoc interpretation carries a 54% error rate and 4 times the risk of a clinically significant mistake. So it's always there, it's everywhere, the need for professionalization. Moving on to the next question for Michael or Natalya. As certifying bodies, as certification bodies, how do you address the professional development and credentialing of interpreters specializing in languages of lesser diffusion? Especially given the need and sort of the lack of representation from languages of lesser diffusion. Particularly given that few such organizations offer dedicated pathways or possess the institutional resources to support them as well.
I can probably start off on that one. So for NAATI, I mentioned before, 8,800 practitioners, 190 odd languages. We test 71 languages professionally. There is over 400 languages spoken in Australia, including 130 odd native Aboriginal Australian languages. For us, there's over 7,000 languages in the world as well. So it's going to be very difficult. Like, as far as I know, we're the largest for testing in the world. But there is always going to be a limitation for having not only the people that want to take the test, but also the examiners that can mark it to make sure it's reliable and replicatable. So there's always going to be a balance. For us, we use census data. We look at the top number of languages spoken at home rather than English. We have great census data here in Australia that allows us to do that. And we also get self-reporting on people that don't speak English well or not at all. Again, self-reported, so you can only do what you can with that. But so for us, the languages that we look at cover about 80% of those people that speak it at home. So over 400 languages spoken, but those 71 that we test cover over 80%. For the ones that we can't test, about 120 in the system at the moment, we have the same requirements. So NAATI, since 2018, has a requirement for everyone to have formal training in interpreting or translating at a minimum standard before even being eligible to take a test. And then if we've got a test, we test it. Where we can't test, this formal training still exists. So there is still a base level understanding of ethics, intercultural competency, note-taking, professionalism. That's all still there. But then instead of a test, we utilize work references and work practice, or references from friends, family, etc., to gauge a level of competence. It's never going to be as good as a test, but that is how we sort of get around that part. But then we hold those practitioners to the same level of rigor afterwards as well. So they have the same professional development requirements, and they have the same need to adhere to the code of ethics. So if it's not as good, but in a world where there's 7,000 languages, we're never going to be able to do them all.
Yes.
So having that minimum level of training, adherence to a code of ethics, and a requirement to do ongoing professional development, we believe is the way to at least make that worthwhile. And then, I guess I'll step back one bit, just pick up on one of Natalya's points where that AI is being, sold as the cure for everything. In high corpus languages, it's fantastic, right? For 6,990 of those 7,000 languages, it is not good. We've tested it against our test. Languages like Spanish, French that have got high corpus to draw from, great. Terrible for interpreting, pretty good in translating. For everything else, like languages like Burmese, it was nonsensical when it went through our test. Wouldn't have even come close. So if you're relying on that for doing lower diffusion languages, you're really walking into a disaster.
Yeah, and Burmese is actually relatively common compared to many of the other languages. So I can only imagine.
Yeah. Well, let me pick up here. So we obviously face the same problem that Michael just described, right? And there's no way we could develop bilingual interpreting tests for every language possible. So we try to look at it from a different perspective, and we try to separate what is language specific in interpreting from what is not, right? And that was, we conducted a multi-year research study that demonstrated that there are the core cognitive skills of interpreting that could be tested in a monolingual English format in our case, but it could be obviously transferred to the same monolingual format in other languages. But and that's how we created the English to English exam, which combined with the written or knowledge core CCHI exam that tests your knowledge of the code of ethics, of medical terminology in English, that created the core CCHI performance credential. And so that's why now we're really proud that we can say that we certify any language, to recognize that certification is not just a test or a combination of tests, that it's more than that. And one important component that Michael mentioned is what happens afterwards, which is holding the credential holders, the certificates accountable through continuing education, through disciplinary processes, to adherence to code of ethics. We also opened the gate, so to say, by adjusting our language proficiency standards. About 3 years ago, we introduced the tiered approach to languages, and the tier 3 languages are the languages that don't have language proficiency tests available. We assess their language proficiency kind of as a combination of what Michael described through documents, 2 types of documents, through the employer and through the community organization that could describe how that individual interacts in their non-English language with the community or with the interprets in the maybe non-healthcare settings. Now, obviously, it is not that certification, even though it's available for everyone, it does not solve the training pipeline problem, right? Because interpreters of languages of lesser diffusion still need to be trained. They need to be mentored. And even to qualify for exam, in our case, they also need to complete at least 40 hours of medical interpreter training. They need to have those language proficiency, meet the language proficiency requirements. But we also need employers who actually schedule these interpreters who will go through the path of certified. Like we have right now in our registry, Navajo certified interpreters. We have Quiche certified interpreters. We have interpreters of African languages certified. So we have a good array of languages who can obtain this certification. But what we hear from our certificants is that we obtain the certification, but that employers are still prefer to hire the person from the street, in my opinion. In other words, individuals who they know somehow think they could do the same job so that they can pay them less than a certified interpreter. And that's something that we together need to work on. Trainers, language companies and associations, because as a certifying body, we can guarantee that the credential itself will never exclude a language. It will always be available. That's our mission, our goal, and that's the resources we put towards that, right, to maintain that promise. But we need the help of associations to move it farther in terms of like making it really realistic for interpreters of languages of lesser diffusion to seek certification. So we have a lot of things to do, but this webinar is one of these little steps, right? You have these little building blocks. Like today, maybe somebody learned about it and they will we'll take one more step towards it. And together we will overcome this problem.
Absolutely.
Yes. And Natalya, I have a question for you, and I think you touched on this a little bit already. And it's kind of like 3 questions in one. So feel free to choose what you would like. And obviously, Michael, chime in at any point. What has driven casualization and low pay in the profession? That's one. Beyond certification, what policy or institutional changes at the hospital, payer, or legislator level do CCHI and NAATI consider the highest leverage opportunities right now?
Yes, we talked about it before, right? That the answer to the first question is procurement, right? We did not drift into casualization just by chance. We were kind of pushed into it, and it is not a mystery how, right? It is predictable. If you are buying interpreting by appointment or by the minutes, if you are not requiring any credentials, if you are buying from the cheapest source available on the planet, right? That's what you get, right? If we walk through that, first thing is global price setting, right? Remote modalities made it possible to route US patients to interpreters anywhere in the world. And, according to our study, 78% of overseas interpreters that serve US patients earn $10 an hour or less. And 39% earn 15 cents a minute or less. Right? And that price anchor for the overseas interpreter, of course, will be dragging the US prices for the rest of the workforce. The other one is I want to touch upon is cost shifting, right? At least according to our study, again, 46% of our workforce are freelancers. It's a blessing for some, but the profession cannot act as the freelancer, because what you're doing is you're shifting the cost of the benefits, you're shifting the cost of the time between the calls, because most interpreters, remote interpreters, are paid just for the call time, not for the breaks, not for the prep, right? Most freelancers buy their own equipment, pay for their own internet. All that cost, that overhead that normally would sit in the employer as their fixed cost, is shifted to the interpreter. That even drives the thing later. And as I mentioned, since there is no requirement for certification, for credentialing, when the buyers don't see quality, they will be competing only on what they can see on the price. And they cannot see quality if language providers do not require certification, training, language proficiency testing. It's kind of like chicken and egg, right? But that's how it is. And I think it's an invisibility too, because we really are, again, back to that cost center things, we really very rarely appear as a billable service to the patient, and that's or to the provider. So we're in the invisible overhead, and that's the one that gets squeezed. But as far as like your second part of the question, and what can we do? What is the leverage that we have? I see like 4 different levels, and the highest impact is back to what I said earlier, is that we need to expand state Medicaid and CHIP reimbursement for interpreting. I know in the US, we hear that on the news recently a lot, because the programs have been, cut funding, etc. But we always think of it as the lower income individuals who need it. You need to think of this. Medicaid and CHIP is also about interpreting services. It's not just about the recipients, it's about the profession. And we as professionals need to engage in advocating there. Right now, according to the National Health Law Program, only 18 states out of 50 reimburse for interpreting services.
Wow.
So, 18. We can do better, and we should be doing better. Looking at the legislative level, a little bit like this was federal, the legislative level, again, back to that state of New York, that law is really good. It requires interpreting services, language assistance programs. It also speaks about not allowing children to interpret. So it was actually signed by the governor in December of 2025. So why is it just the state of New York? What's wrong with the state of, California, for that matter, right? It's not the only state that is considered progressive in the United States nowadays, right? There are many other states that could do that. And then the institutional level, I'm thinking about the, when certification is requirement, as hiring practice and as your contracting practice, then we can move that needle, right? Because, and that's how we can also improve our working conditions. If we take that, data from the survey to the individuals and show them like, hey, I need to renegotiate this. You need to pay me for the time between the calls. In the state of California, if you work 4 hours, the employer is required to pay you 15 minutes for your rest, right? Why is it just in one state again? And finally, the one thing I want to bring up, we need to remember that in the healthcare, we do have one big player who issues standards, which is the Joint Commission. And recently, this year, the Joint Commission moved the language services into safety of the patient part, right? We're called that Goal 7. Remember that name and search for it, because in that Goal 7, it says that the hospital respects the patient's rights to and need for effective communication. And the next element there is the hospital provides interpreting and translation services as necessary. So that's the, how do your institution is going to comply with that goal. It's not just about nice to have, it's the clinical safety tied to marker right now for hospitals' performance, and that's what we need to educate about.
Wonderful, wonderful. So much good information.
If I'll throw in a little bit, I did mention before some of the reasons I thought that the pay was problematic. The big things I would add to that from prior is that people working as individuals don't have the bargaining power that groups do. And I strongly recommend, as part of our recertification requirements, we actually give a fair amount of points towards membership of professional associations, because we think that professionals working together that can share ideas, strengthen each other, lobby more forcefully with each other is a big thing. There are other industries that are far less professional that get quite high pay because they have strong unions and have strong associations. So I think that can't be discounted, in addition with the other things around um, you know, migrant workforce, female participation, social care. I think they're all valid points as well. For us, the procurement is really the thing that we're focused on now. NAATI this year just introduced, at the request of owners, the governments of Australia, language service provider endorsement program. So we've been certifying individuals for decades, and local states have their own language policies that will say you should use someone certified or professional. The problem is the enforcement of that. So our language service provider endorsement model is linked. It's only started. I can't give proper detail on it yet, but part of it is governments that are procuring services need to only procure them from someone that is endorsed. And terms of that endorsement include conditions for the interpreters, ensuring that they have the right workplace and support and training, but also the data that shows who's being used and what certification level they had. So over the next year to two, we see that that's going to be an important part of us helping governments enforce their own standards, because we'll be able to be the check and balance in that scenario. Concurrently to that, we've also, for the first time ever, our amazing comms team have just launched an awareness campaign for consumers. So in Australia, the translating interpreting service is free, so we don't have that cost pressure for the consumer or the hospital necessarily. And that's been around since the 70s. But just informing people of their rights, that they can access an interpreter, and then if they access an interpreter, they should ask for a professional. So we're doing a bit of a consumer awareness campaign. So there's the top-down thing, which is working on procurement, working on language service providers, but then there's the bottom-up, so that the people asking, so anecdotally, we're already hearing some positive things around it. Bottom-up going, I need an interpreter, and make sure they're a professional, because that bottom-up will help as well.
Absolutely. Absolutely. Like the deaf community. The deaf community is very good, very informed about advocating for their rights. It took a long time to get there, but they're certainly there, and I think we could all learn from them as well. Okay, so we're approaching time. We have about 7 minutes left, and we certainly want to respect everyone's time. But looking ahead, what is one initiative, whether a scholarship program, a policy campaign, an institutional endorsement framework, which you just alluded to, Michael, or something else entirely, that CCHI and NAATI are really, really excited about, and that participants can get behind? So kind of summarizing all the themes of the conversation for today, would love to hear your thoughts.
Well, I start off, going on from my previous point, the endorsement framework for providers is the thing that we're probably most excited about at the moment. We think that it's one of the missing planks that will help. But then I think more broadly, I truly believe that there will be problems with AI use. People are going to jump into it. It's going to lead to some pretty bad outcomes. This is ridiculous that I'm saying this is a positive, isn't it? I will keep going with the comment though.
Hmm.
I think there is going to be a backlash against the use of these technologies. One,
Yeah.
the lack of humanness around it. How many times does Siri get a basic command wrong? And do you believe that that can really be appropriate in a hospital setting? It should absolutely take low value work, booking appointments, getting basic information. But just like the medical profession's got um, Google or a first aider or a local pharmacy as first lines, AI, machine translation, they should all be first lines for stuff to help accessibility. That's absolutely correct. But I think that professional associations and interpreters and translators advocating for what the value of professionalism is for those higher value roles, I think that's what's exciting. I think that should be really the focus of everyone, and leave the low value stuff that can be taken care of by a machine or someone untrained. That's great. But there's a lot of doom, I guess, if you just read the news around it. But I think there is a real positive here that humans matter and professionals matter.
Mm-hmm.
And I really do think there'll be quite unfortunately, some disasters that come from people cutting costs. And hopefully that spurs a bit of a backlash.
Absolutely. But even the low value appointments need some level of human oversight,
Yep,
right? So it's never
absolutely.
going to be a level of sign off, a level of, just being there, because things frequently have to get escalated.
Correct. Yeah, that's something that, we can never predict in a healthcare setting, especially, right? How a simplest thing could get down,
Any
become
setting,
very
right?
serious very
Mhm.
quickly. And so, until they create the handoff mechanism from AI to human, it's really hard. It's really risky to put everything to AI. So, to answer your question from our perspective, one initiative that I want everyone to get behind is our global workforce survey for healthcare interpreters, and look at it from the two perspectives. The results, the reports from 2025 one are on our website, and I'll click let's paste the link in the chat in a minute. And I would like everyone to use it because it's meant to be
Mm-hmm.
quotable. Take it to your conversation with administration. Email it to your administrator. Hey, have you seen this? This describes our profession and our pain points, and that describes other hospitals. See how our hospital fits into this big picture. But the most important thing I want to say about is, please participate in the next iteration, because guess what? We're only 6 months away from the next, survey. So early next year, 2027, we need everyone to take it. So because our arguments become stronger if we have fresh data to support
Yes.
them. And also if we can now start seeing some trends, because this will be our second survey, but we already can compare it to the first. And if on the first one, there were just very few individuals who said they use AI, I can imagine how many now would say they use it, and would be interesting to see to what purposes, because that question existed there also. And then another thing I want to mention is that CCHI does offer scholarships for our English to English exam. We do it twice a year, and the next cycle starts in September. And so in my chat right now, I put both links to the scholarship and to the survey, but just stay alert next year and participate in it. It only will take 15 minutes of your life, but you will help others, not just us with that. And I want to say that, when we talk about the future in general, that the future of our profession is, as we all know, not something that happens to us. We're the ones who define it. And to just kind of finish off on the theme of this webinar, we build it by getting certified, by bringing data
Mm-hmm.
to and accountability to our, administrations, to different providers. And that's what makes us irreplaceable and indispensable. So thank you for the opportunity to kind of air some of our thoughts. Michael and I could talk for 2-3 hours more, I'm pretty sure. But because we just started getting warmed up here. But thank you for the opportunity.
Thank you, Natalia. Thank you, Michael. Wonderful conversation, always enlightening. It's great to have the perspective from Australia and really impressed with
Yes.
all the work happening in Australia.
Yes. And again, from CCC, thank you so much, Natalia. Thank you so much, Michael. Thank you to all the participants from all over the world that join us today and tonight and this morning for you guys, August 6th. And thank you to our ASL interpreters, Madison and Allison,
Yes.
for interpreting. There you go. We need it. So with that, everybody, it's 7:00 p.m. Eastern time in Indianapolis, in the United States. And everyone have a fantastic evening. Thank you so much for joining us.
Have a
Till
great day,
next
Michael,
time.
in Australia.
Thank you all.
Thank you. Enjoy
Thank
your Wednesday. No, Thursday. Is it
Thursday.
Thursday?
Thursday.
It's their
Thursday, yes.
Thursday.
Enjoy
It's
your
our
Thursday.
Wednesday night. Thank you, everybody.
Thank you, everyone.
Bye.
Thanks.